So as we begin the meeting, I just want to first and foremost say, Dr. Buchalter, thank you very, very much for joining us. We and our entire community really appreciate your presence here. And we know that while this is a difficult conversation, it is also such an important one, and we all have a lot to learn. So I want to let everyone know that I'm going to put in the chat Dr. Buchalter's full bio. But just to give a bit of an introduction right now, I will let you know, Dr. Jeffrey Buchalter received his pediatrics training at UCLA Harbor General Medical Center, followed by a pediatric neurology residency at the Harvard Longwood Training Program, and fellowships in clinical and basic electrophysiology at Beth Israel and Boston Children's Hospital. He's also been connected to several committees and patient groups, and that includes the Child Neurology Foundation, which is how we at NTSAD came to be connected to him. So Dr. Buchalter, you are obviously very qualified to speak to this information, and we are so thankful to have you here. So I will let you take it from here.
Okay, thanks, Becky. So I'm going to share my screen. And you need to let me do that because it says it's disabled.
Gotcha. One moment.
Okay. And if folks would like to turn on their camera, if it's not too disruptive to your life, that would be great. Otherwise, I'm sort of sitting here talking to myself. It makes it feel more in person. So I'll try to share again. Thanks. And if it's uncomfortable, that's fine too. Bye.
Yep. Okay. Coming right now. Okay. You should
Ready?
be able to share your screen now.
Okay. Okay. Great. Okay. Well, good evening, everybody, and thanks for coming and discussing some seizure-related stuff with me. Please, as we go on, if you have questions about the presentation or anything, just either raise your hand or pipe up, because part of it's going to be a little technical, and if you have questions, chances are other people will as well. So that's absolutely fine. Or put them in the chat box if you'd rather not, and Becky will draw my attention to it. So in terms of disclosures, it's really sort of how I got here. I'm a retired pediatric epilepsy physician, which means I stopped seeing patients about a year ago. It also means that I know a lot about epilepsy, but very little about the disorders that your foundation covers. There's been an explosion in knowledge in this domain in the last 20 years that I'm not an expert in, and have the greatest respect for your neurometabolic or genetic clinicians that do. So my knowledge is limited there. The things that I am involved in are sort of listed below. Probably the two most relevant are, the first is the Partners Against Mortality in Epilepsy. And this organization, which has now been around for about a decade, is concerned with trying to prevent premature mortality in epilepsy, death related to seizures. And so as part of that group, we spend a lot of time that have lost loved ones, children, adults, to epilepsy. So I know how difficult these conversations are, and we'll try and approach it with the greatest sensitivity. I was told by a parent early on that I was being too sensitive, and not just getting things out there and talking about the realities of their world. So try and strike the right balance. The other organization that I've participated in, something called the Rare Epilepsy Network. And these are the epilepsies that are uncommon, therefore rare, but usually have a genetic basis. And it started with about 20 organizations 5 years ago, and now is up to about 80. And so in some ways you touch this kind of thing, because although the disorders that involve your lives are not very common, they're very serious and frequently associated with premature mortality. The other things I'm doing are listed. I won't go into them, so I'm not quite retired. So questions that I thought we could talk about today are here. How do you know if someone's having a seizure? Becky and I have talked a whole bunch about that. Are seizures common in the disorders involved in your organization? Some general knowledge: what causes seizures, what are the types of seizures, and what's epilepsy? And then the hard one: are seizures a cause of death, direct or indirect, in the disorders involved with National Association? So for starters, how do doctors think about children and adults who are having things, which we'll talk about, movements, staring, whatever, to diagnose seizures? And the first thing I want to emphasize is that a primary consideration is making sure that something isn't a seizure. Something is not a seizure, because as soon as you go down this pathway, it leads to all kinds of other things and treatment. So we always ask the question, is this a seizure? What are the things that could be a seizures, and how do you know? Well, if a child is staring, has decreased responsiveness, jerking, stiffening, those are all possible seizures, but not necessarily. If you see that stiffening, shaking, turning blue in the face and unresponsive for many minutes, that's likely to be a seizure. However, there are kinds of electrical seizures that can occur during sleep and awake, where the child is doing nothing that looks different, but is having a seizure in their brain. So in addition to thinking about what's possible, there's a test called a video EEG, which is the best we have, so I put definitive, but not perfect. So what do I mean? So now we look at something that happens clinically, what we see with our eyes, and what the EEG shows us to see if it's a seizure. So in this first example, we have someone that stares, jerking, and stiffens, starting over here. The EEG is normal before it starts, and then gets this spiky rhythmic activity. This is diagnostic of a seizure. So in this circumstance, we know it's a seizure. So that's a firm diagnosis. What about when you have the same staring, jerking, and stiffening, but you don't see any change in the EEG? That's referred to as a non-epileptic event that you're not going to treat with medications. And the one that is
headphones.
the one I think is most frightening of all is
Do
someone that's sleeping and their EEG starts normally, but then it
mute
becomes
audio.
a
I
seizure.
just unmuted it. Start video.
Nope, someone's figuring out the system. It's on the lower left on my screen.
There we go.
Just click mute. Or if you want to talk, leave it on. And so the child is not doing anything that looks like a seizure, but the brain is having one. So 3 different kinds of events. So the first question, what about seizures and Tay-Sachs and associated diseases? And I did a quick look, and the information wasn't easy to find.
Mhm.
And I'm pretty good at finding stuff. For Tay-Sachs, there was the most. Seizures usually happen by 12 months. The types are called tonic myoclonic, myoclonic, generalized focal, and gelastic, meaning laughing. And I'll describe these later. And these can be drug resistant. So sometimes just by starting a medication doesn't get better. In Canavan's disease, 50% of patients it's written have seizures, generalized tonic-clonic. The beta-galactosidase listed as myoclonic. For Sandoff is listed as seizures. And for Farber type 5 seizures, again, no great description, but was said it can be drug resistant. So are seizures present? Yeah, and it's just what types, how many, and responsiveness to medication. So this is, I think, a reasonable topic. Now let's move on to some basics. What causes seizures? What are the types of seizures? And what is epilepsy? So the overview is that the brain uses electrical chemical activity to function. Everything we do in the brain is via communication by chemicals that cause electrical impulses. So in this cartoon, this is a brain cell, a neuron. This is an extension from it called an axon. And what the lighting is about is that's where the chemicals are released and it causes electrical activity in the next brain cell. That's normal function. A seizure is when too many brain cells fire all together out of control. And so if you look, have an idea of how we do things, you want the brain cells to fire, but you want them to be coordinated, not too many, and stop when you're done. A seizure is when all these things are happening out of control. And where they happen determines what it looks like. So what can a seizure look like? And the simple answer is a seizure can be anything that the brain does. It can be moving uncontrollably, called a motor seizure. It can be a tingling or a sensation, called a sensory seizure. It can be seeing and hearing things that are not there, hallucinations, but are seizures. Seizures can also take away normal function, so-called negative seizures. And the biggest one is taking away awareness, staring and unresponsiveness. I used to staff an autism epilepsy clinic for 5 years. And so in the autism population, kids stare a lot. So it was a real challenge to figure out, is this the staring that goes with autism, inattention, or is it a seizure? And as I mentioned, the type of seizure depends on where in the brain that it comes from. So over here is where movement comes from. So if it starts over here or gets over here, they're shaking. Over here is where you feel, so there can be abnormal sensations, and awareness is over here. So that's the quick trip through neuroanatomy, but it's relevant to where we talk about seizures. So this is the really hard part, I find, not only for parents, but for a lot of doctors. How are seizures described? And the answer is in a whole bunch of ways, which is confusing. Okay. So if you get confused, just raise your hand and we'll deal with it. So they're described in a number of ways: how and where it starts, how it looks, and the cause. All kinds of descriptors. So how it starts, you might hear the words partial, focal, or local. They all mean the same thing. It means it starts in one place in the brain. can be, adjacent to each other. It can stay in one side or spread to the other side, but it's focal, starts in one place. Generalized means it starts on both sides of the brain simultaneously. So that's the sort of the localization, how it starts, descriptors. How it looks. And you're going to see a lot of redundancy here. So I put focal again, but if it looks like someone is shaking their right hand or the right leg or one side of their face, that would be a focal seizure. Generalized, same idea. If someone's moving both sides of the body simultaneously, that would be a generalized seizure. So these two terms are used slightly, they sort of mean the same thing, but they're used differently. Now here's a big one, a convulsion. And that's when the whole body shakes. This is what's referred to as the grand mal seizure, or some people just call it their big seizures, convulsion. Tonic means stiffening. And so most commonly it looks generalized, meaning it's the whole body stiffening out. It can be one or more limbs, but most commonly it's stiffening. And you're probably wondering, does all stiffening mean a seizure? And the answer is no. Atonic means loss of tone, and that's so-called drop or drop attacks. And these occur suddenly. It can be a whole body, or it can just be a head drop, an atonic seizure. Clonic means rhythmic jerking of an extremity or both extremities, 2 to 3 times per second, clonic jerks. Myoclonic means a sudden brief jerk. If you've ever seen someone or yourself fall asleep and then wake up quickly, or during sleep you wake up and jerk, that's called a myoclonic jerk. This is the single probably biggest problem in diagnosis, because you can have myoclonic jerks, which are the result of a movement disorder or sensory responsiveness, or a myoclonic seizure. Is it easy to tell them apart? Absolutely not. But those are myoclonic seizures. And impaired awareness, talked about, a disturbance of thinking, attention, doing stuff. So all of these are how it looks. Another one is, what's the cause? And I've just listed the common causes and put in larger font the genetic causes, which are most of the disorders that you're familiar with. In the epilepsy world, those genetic causes are referred to as developmental epileptic encephalopathies, because there's a lack of development, there's seizures, and involves the brain. Your disorders have not traditionally been considered epileptic encephalopathies. This is to show you what your doctors see in this sort of a formal classification of seizure types. And you see how it's done, where it starts, how it starts, focal onset, generalized onset, and we don't know. And then it breaks it down into the different types that we've discussed. So that's the doc side of it. There's another couple of words that I want you to just want to talk about, because you may have heard them. One is secondary. This is a secondary seizure. And what that means is it's secondary to a cause, like a stroke, or like a tumor, or like Tay-Sachs. There's another word, symptomatic, which means exactly the same thing. And it implies that a seizure is a symptom of an underlying cause. In the olden days, when I was new, 50% of seizures were of unknown cause, called idiopathic. With time and genetic discovery, it's now much less. So these are two words that you may hear. So now we're going to move from seizures to epilepsy. What is epilepsy? Epilepsy in the olden days was defined as 2 or more unprovoked seizures. Meaning if you had a high fever and a seizure, it wasn't an epilepsy. It's been expanded, the definition, to 2 or more unprovoked seizures, but diagnosis of an epilepsy syndrome. And there are syndromes like childhood absence epilepsy or Dravet syndrome that are epilepsies because they have recurrent seizures. The third way to have an epilepsy diagnosed is if the likelihood of a second seizure is 60% or greater. And this is the most problematic because it's not defined for a lot of situations. But anyway, these are the definitions, modern definitions of epilepsy. And again, what the doctor sees, the formal definition of the epilepsies. Notice how it starts the same way: focal, generalized, unknown seizure types, and epilepsy types, and then fold in the etiologies. So this is where you guys would fit with the genetic and the metabolic. So that's what your epilepsy doctor sees. Now, to move on from the general stuff to the mortality stuff. And when I did my training, we never talked about people dying related to seizures, except if they had aspiration pneumonia. In the last 2 decades, this field has exploded. And a lot of the thinking, and you'll see it on some of the references, 2015, 2019, we now know that seizures, the epilepsies, can be life-threatening disorders. It's interesting how organizations develop. The Epilepsy Foundation, which is the largest parent advocacy organization, for many years had a byline of living well with epilepsy. That was to make it feel good for those that were neurotypical. But it was wrong, because we realized that many people with seizures do not live well, and that some die before their time. So this is relatively new thinking in the seizure domain. This is a list of epilepsy-related deaths by group. Deaths due to epilepsy, sudden unexpected death in epilepsy, which I'll talk about, status, and other things. Deaths due to acute symptomatic seizures, like if you fall off a truck and have seizures and pass away. Deaths indirectly due, aspiration pneumonia, suicide, and deaths due to underlying neurologic disease. Right down here are the metabolic, degenerative, and neurodegenerative disorders. What I want you to start thinking about, because I didn't think about this until Becky asked me to do this presentation, is what role do seizures in your children have with regard to aspiration pneumonia, status, and sudden unexpected death in epilepsy? And the reason for starting to think about this is prevention. It's not an academic thing in my mind. It's comes down to, if someone's having seizures, why treat them? And I would submit to you that these are three potential reasons. And as I said to Becky before we started the session, this isn't something that at least I've ever thought about, and I know that my colleagues haven't. So you're sort of hearing it for the first time. So sudden unexpected death is defined, SUDEP, is defined as non-traumatic death in a person with epilepsy without post-mortem exam evidence of structural or toxicological cause of death. That means that if a person with Canavan's disease who had many seizures died, the pathologists would not classify it as SUDEP because they had Canavan's. We can ask the question, is that correct? It is only relatively recently that the medical examiners have become involved. This is from 2018. We started this effort in 2014. And so the reason that we don't know a lot about causes of death in epilepsy is that those responsible for putting it on the death certificate were not familiar with this diagnosis. So a lot of improvement that we need to do in our ascertainment. Now, step back, and this was a publication by Elizabeth Donner in Canada in 2017, where she put together all causes of death in children with epilepsy. 4 studies. The first cause was epilepsy-related status, aspirations, complication of treatment, and SUDEP. The second was non-epilepsy related, natural and not natural. And I put in blue here, this stands for neurometabolic disorders. So this is considered non-epilepsy related. And uncertain, we just don't know. Now, when we look at the non-epilepsy related deaths, pneumonia is the big player in all the studies. So we asked the question, is pneumonia preventable, and what role do seizures have? It was only in one earlier study by Ann Berg that metabolic and neurodegenerative conditions were diagnosed and included. So it's sort of been there, but look, we haven't paid adequate attention. When looking at epilepsy-related deaths, I thought status would have been the big one. I was wrong. It's sudden unexpected death in epilepsy, SUDEP. So new thinking in our world. I put in this slide to remind me to say to you that the majority of SUDEP deaths occurred during sleep. And this was a study from Sweden where the combination of not sharing a bedroom and having the grand mal seizures increased risk by 67 times. So these are big factors. This is a study that was published again in 2019. And what I'm doing is looking for ways to make this relevant to you. We just discussed the found in bed, asleep. We just discussed the generalized tonic-clonic seizures, the grand mal. But looking at this review of the literature, there were only 5 instances reported of genetic chromosomal, which again relates to people haven't been paying attention, because we suspect it's much greater than that. This is another publication 2019 from the North American SUDEP Registry. And there are a whole bunch of epilepsy syndromes listed here. And these are the ones that epilepsy doctors focus on. The numbers 13, 9, 9, da, da, da. 64 were completely unknown, but 33 were genetic. So it's there, but I don't think, been paying adequate attention. This is another example of it from 2013, mortality risks in new onset childhood epilepsy. There's a total of 3 studies with over 2,000 patients. But I read it again with you all in mind, and from the analysis, they excluded children with lethal metabolic conditions, neuronal ceroid lipofuscinosis, and others. So again, we know that it's occurring. I want to close with asking you a question. How often have your doctors discussed the role of seizures in mortality? You're all here because you have loved ones with potentially fatal conditions. And I think part of the disclosure thing with families is talking about the worst of all potential complications. And so how often has this been brought to your attention? I can tell you that in the world of pediatric epilepsy, it's discussed in children, with families and children with epilepsy, in less than 50% of instances. It's actually closer to 20%. So this is a study that from the United Kingdom, looking at a pediatric epilepsy population. And to the shock of many, 3/4 of pediatric neurologists only discuss SUDEP with a select group of patients and children. In the same study, 91% of parents expected this information to be provided. So there's a big disconnect between what we were doing and what families want, and they wanted it at this time of the diagnosis. So it wasn't way down the line. Families want to know what the worst possible outcome can be. So what are the reasons that I would offer to discuss and treat seizures to decrease the likelihood of death? Aspiration pneumonia, were these seizures that caused it? Status epilepticus, something that we recognize. And SUDEP, sudden unexpected death, where we didn't recognize it previously. The idea is knowledge is power. And in the Rare Epilepsy Network, I can tell you that those family advocacy organizations have been major players in educating their doctors as to a whole variety of things, including SUDEP. So to summarize, what are the challenges? The first, and I think really big one, is to identify if you see an unusual posture or movement or breathing pattern, staring or decreased responsiveness represents a seizure. That's a big one. And then the next one is your decision if the effort, expense, potential side effects of anti-seizure medications is worth the potential benefit and quality of life and or prevention of premature mortality in your kids. It's your call. It just needs to be presented to you. And I think these issues are just best addressed one-on-one in the office with your neurologist. And so with that, thank you for your attention and be happy to answer any questions.
Thank you, Dr. Buchalter. I know I learned a lot just now, even with the statistical data that you shared. It's so important for everyone. I wonder, before or while we open it up for questions, one thing that I had at the top of my mind is if you could speak to perhaps the role that sort of a triggering factor for starters, especially in our children. I know with my daughter who had Tay-Sachs disease, positioning could trigger a seizure. The over-exaggerated startle reflex could trigger a seizure. So I was wondering if you could speak a little to that as well.
Sure. One of the ways that you know that something isn't a seizure is if by positioning you can start and or stop it. You can't do that with seizures. So those are hyperactive brain reflexes, if you will. Positioning is very important in another regard, particularly during sleep, because one of the mechanisms that's hypothesized for SUDEP is obstruction of the airway, or lessening of the muscles that control access to the lungs. So position is really important.
Thank you. And if parents are beginning to see these things or they have questions on these things, when they do visit their neurologist, what would you suggest or encourage that they could ask, or what would be an appropriate way to bring this up to get some information? What keywords could they discuss?
So you can make me the bad guy and say, I heard a presentation by some pediatric neurologist who said these things could be seizures. And the best way to do it now is take a video.
Mm-hmm.
Video on our cell phones has revolutionized
Mm-hmm.
our efficiency in the office, because sometimes you look at, when I was practicing, you look at something and say, wow, that's definitely a seizure. Or conversely, that's not a seizure. Or in the middle, I'm not sure. But the ability to give your docs the knowledge that you have, what you're seeing, is the way to go. And I wouldn't be shy about it.
Mm-hmm.
I think most physicians will ask you, do you have any questions? And I always advocated for my families, to write them down before you get in the office, because sometimes in the flow of the office visit, things are so busy and so much to pay attention to, you can forget. So I would, three big things. Number one, make sure to do it. Number two, write it down. And number three, if at all possible, come with a video.
Yeah, that's great advice, especially today. We all have our computers right there in our pocket and we can video everything in an instant. So thank you so much. Are there any other questions that anyone has that we haven't gotten to so far? Feel free to raise your hand or speak or put it in the chat and we can facilitate answering those now. Yeah, Ashley, please go ahead.
Hi there. I have a couple questions regarding seizures, kind of to back up what Becky was saying earlier regarding like triggers for seizures. It seems that our little guy can be set off pretty easily. Like if he's constipated or having trouble with reflux or something like that, that if those aren't well managed or under control, then we do seem to see a higher frequency in seizures. So, and then if we can get those things under control, then the seizures do tend to taper and space out a little bit more. So so that's one of the things we do is we try to kind of keep those things at bay, or everything at bay, or like a balancing act, you know. But from what you said, it sounds like it may not be the case. And then I had another question regarding, let me not forget it. Are there some seizures that are less concerning as far as how imperative they are than others, like a galactic seizure, or one where, like there's one that our little guy does recently where he like is breathing, but he looks like he's passed out, or just like a stiff one versus a tonic one or whatever. So I just don't know if there's some that we should be more concerned about than others, because our neurologist seems to downplay the galactic seizures, like, oh, that's not a big deal, you know, versus other ones she might take more seriously. Those are my two questions.
Yeah, no, they're great questions. Things like constipation, and in one of the studies that the Rare Epilepsy Network did was asking, you know, the members across very different disorders, what are the so-called comorbidities or coexistence kinds of things, and entities like constipation, sleep disorders, behavioral disorders were common across, and you know, big ticket items when you're living with them. So, you know, to no way downplay them. If someone said to me in the office, I think when my child's constipated, they're having more seizures, I would recommend two things. Number one, treating the constipation, because that in and of itself is horrible for anybody. And the second is, be sure that these are seizures. Because if you're not, you can end up treating something with a medication that has its own side effects and doesn't work. You're taking on risk for something that you may not need to. So that would be the first decision point. The second question, you know, are some seizures more worrisome than others? And yeah, the answer is yes. Seizures in which someone giggles, it's not a mirthful laughter. You know, it's not it's not like someone's really happy, but it sort of looks like it. Those are not thought to be damaging or dangerous. A seizure in which someone stops breathing is really dangerous. And then seizures in which there's like you said, tonic or clonic shaking, those are also dangerous because they're associated with SUDEP. Is there another kind of seizure that we don't think is immediately dangerous? Yeah, like when someone is shaking of the hand, they're breathing fine, they're intact, but that's a focal motor seizure, not as dangerous. And that plays into your decision with your neurologist about what you want to treat. If someone's having seizures where the kid stops breathing, then that's a pretty big deal. And that's a must treat in my book. If someone's having a gelastic seizure, not necessarily so. So I hope that sort of gets to it.
I have a question. Can you hear me?
Yes, shoot.
Oh, okay, perfect. Lily, something you were just talking about. My daughter Lily is 8 years old, about to be 9. We've only had a couple of EEGs over her life, but her seizures, we've never really seen a seizure, but they have her because of just abnormal spiking on something called trileptal, and we have a rescue med that we've never had to use called clonazepam. Mm-hmm. So what you're saying is that some of it's not necessarily needing these medications? because we've never seen an actual seizure in her, but she does random things like she suddenly jerks in her sleep, she sits up, repetitive talking, but never where she's lost conscious.
Yeah, that's see, and that's really what I was trying to get to. You have someone who's paying attention with an EEG, which is clearly abnormal, or wouldn't have treated, indicating a high likelihood of seizures. And the EEG can be abnormal in a number of different ways. What I illustrated is, those continuous spikes. Those are called electrical seizures, and they can go on for minutes and minutes. And most people would treat those. There are other abnormalities where it's just one spike or one blip every 15 seconds.
Yeah, that's kind of what happens with Lily. It's like continuous spikes, but it comes and goes, like spike, couple of minutes, spike, like that is what I understood.
Yeah, and so I think that the conversation there is a more nuanced one with your neurologist, to say, you just want to understand what's being treated. And the two buckets that could fall into are, the EEG is so electrically active that there's a great concern that a seizure could occur, preventative. Another bucket is, are you seeing electrical seizures on the EEG? So that in fact, the trileptal is being used to treat electrical seizures. And having a rescue medication is just fantastic, because when a big seizure happens and you don't have anything, it can be life-threatening, and you're prepared. So, someone's thought a lot about your daughter.
Yes, thankfully, especially because it's so rare to have Tay-Sachs, and Lily being juvenile and she's still walking and talking. So, I'm very, very blessed. So, and then my other question is, as white matter starts to form, like she didn't have this on her newest MRI, showed that there's a little bit of white matter and that the lining between the two parts of the brain is very thin. So do you think that's all more chances for increasing in seizure activity?
That's a hard question. I don't know that anybody, I know that I don't know the answer. And I don't know that anybody does. But it sounds like she's covered, and so you're ready.
Yeah, doing the best, trying to hang in there.
I bet. I know you are. Yes, sir.
Hello, sir. So this is my daughter. She turned 14. She diagnosed like late infantile, 18 months. So she had several seizures in the beginning, different types, like all, the moments that you described. Like, so they started several different medications, and then we're continuing those over the time. The electrical, the EEG reports came out. She doesn't show any activity, but of seizures. But like about 2 years ago, she started doing this activity. Like she just like goes in the front, like lifts her head, kind of. It's a moment, like it doesn't stop on its own. We have to do the position change, sitting up, changing position, like turning her side. Like they call this is a release phenomenon. Yeah. So so the only way we stop is by positioning or nursing interventions. So, but recently, like we started using this medicine called gabapentin, and then it reduced like the frequency of it. But like anything that, I mean, like again, like it looks like seizure, but like it's not seizure. but like it's on the Tay-Sachs kid. With this turned out like about her 11 years, like she had like kind of different medications along the way, but like nothing we stopped. Like we're continuing, though she's not really showing the electrical impulses and all. So about this release phenomenon, I wanted to bring up like if any of the kids or any of this is treated in a different way, or like in the brain, like gabapentin is different, like it's brain injury medication, something like that they mentioned, but it helped, but it didn't stop totally.
Yeah, so I can think of kind of three things. The first is it's always reasonable to ask your doctor, what are we treating with these medicines? Which have their own potential side effects. Sometimes you don't know about them. And what are we treating? Do we need them? Fair question. The second is the release phenomenon sounds like if it's not a seizure, then sounds like you're doing exactly what needs to be done with positioning. And the third, which is confusing, is gabapentin. Gabapentin was originally FDA approved for seizures, but is now used for all kinds of things in neurology, headaches, and peripheral pain, and some movement disorders. So I 100% believe it's made things better. I have no idea how,
yeah.
But because the side effect profile in general is so low, it's certainly something that we like using.
Yeah. Yeah, even the diazepam, those kind of things, like we tried, but like it didn't help. But like this one somehow minimized the frequency and everything. So just,
Right?
yeah. Thank you. Yeah.
You're very welcome.
And Dr. Buchalter, that's one thing we hear often, right? Is, we may never be able to completely control the seizures and have them go away, but we can hope to manage them through reduction. And often that may take various triazepam medications or a combination of various medications.
Yeah, and I think that's exactly right. And I think what I've learned in this preparation is that it's very important to have that conversation, because seizures can have a very great impact with regard to mortality. Other than being a nuisance and hard to watch and difficult to treat, what I've learned is that the efforts to control, if not eliminate, then reduce, are very well founded because of the potential implications with regard to aspiration pneumonia, status, and SUDEP.
Wonderful. I know that we're getting close to the top of the hour here, so I don't want to keep anyone too long past our allotted time. I'll just put out one more push to ask if there's any last question that we can answer for anyone at this time. And also to let you know that please feel free to email me afterwards, and I can always pass something along or look into information more thoroughly for you, and we can stay connected in that manner to keep offering information. Are there any final questions? Well, Dr. Buchalter, it's been so wonderful having you with us. This has been an amazing discussion, and I believe a wealth of information for everyone. So we can't thank you enough for joining us and sharing your expertise with our entire community. We very much appreciate it.
You're very welcome. And if I can assist in the future, please let me know.
Absolutely. Thank you so much, everyone. Like I said, please feel free to reach out. I'm not sure if everyone has my email, so I'm just going to put it in the chat real quick. It's just becky@ntsad.org. So if anything comes up, I'm here if you need it. And like I said, I'll try to get those answered for you. But we hope that you, learned something today and that it's something that you can take forward with. And we hope that you have a great rest of your evening. Have a good night, everyone.
Good night, everybody.